I'd like to recognize Mr. Germano for 5 minutes for your testimony. If you'd like to summarize what you have written and submitted to us and do something other than what you submitted to us, you are all welcome to do that. You're recognized, Mr. Germano. Thank you again.
Chairwoman Eshoo, Ranking Member Burgess, distinguished members of the subcommittee, thank you for inviting me to testify about the Teaching Health Center, Graduate Medical Education, Community Health Centers, and the National Health Service Corps programs. I strongly encourage you to provide increased and stable funding for all 3 programs before they expire on September 30th. The success of these critical programs is at risk when funding for any one of them is jeopardized. Shasta Community Health Center is based in Redding, California, in a predominantly rural and medically underserved region. A federally qualified health center since 1996, we care for over 40,000 patients annually. Since 2014, we've been one of 56 teaching health centers, graduating 8 residents, and we've employed 25 National Health Service Corps loan repayment recipients since 2000. Our 8 THC GME graduates, of the 8, 5 work primarily in underserved populations in Redding and similar communities. Even using these programs, my health center is 4 to 5 primary care physicians short, and it can take up to 12 to 18 months to recruit a physician. So growing our own through the THC GME program is a survival imperative. In 2018, Congress reauthorized the THC program through this September at a more sustainable level of $150,000 per resident. Responding to the primary care physician shortage is incredibly timely because by 2030, we'll need more than 120,000 physicians to meet this country's demands. I'm very grateful that Representatives Ruiz and McMorris-Rodgers have introduced bipartisan legislation, H.R. 2815, to extend the THC program for 5 years. We know that hospital-based training produces physicians whose skills and experiences don't always match the primary care needs of the community and who rarely choose to practice in rural or underserved areas. By contrast, the THC model uses ambulatory health centers in underserved communities for training, and the data proves that these graduates are 3 times more likely to practice in such settings after their residencies. H.R. 2815 will help THCs restore some resident slots that were authorized by HRSA but not filled during the years of uncertainty, and it would fund a very modest increase in per resident allocation to help offset inflation. Lastly, H.R. 2815 expands the program to meet pent-up demand. HRSA last approved a new THC in 2014, and many potential sponsors of such centers have expressed interest in becoming a teaching health center. Our health center depends on the Section 330 grants, which allow health centers to expand their facilities, open new sites, and to meet unmet needs in areas with limited access to care. Section 330 grants leverage other funders because they confer a status of high-quality healthcare provider. Broad bipartisan support for health centers has sustained 1,400 community health center organizations, caring for over 28 million patients in more than 11,000 rural, urban, and frontier communities nationally. The September 30th expiration date threatens the very existence of the health center program. Over the last several years, Shasta and CHCs across this nation have experienced serious uncertainty due to funding disruptions. Our doors are open to everyone regardless of ability to pay. Services are offered on a sliding fee scale basis, and we locate sites in medically underserved communities. However, recent funding lapses threaten the notion of continuous access. We are grateful that Representatives O'Halloran and Stefanik introduced H.R. 2328 to provide 5 years of stable funding for the CHC Fund, including $200 million in annual growth and $15 million in annual growth for the National Service Corps. Likewise, H.R. 1943, introduced by Representative Clyburn, provides 5 years of funding with 10% annual growth, an addition of $4.6 billion for health center capital funding, which would further expand the Corps. Shasta has benefited greatly by the Corps. Over 50 years, the Corps has effectively placed more than 50,000 people in the highest areas of need in our country, so they can provide primary medical, dental, and/or mental and behavioral health services in underserved communities, with more than 10,000 placements last year alone. Our clinicians have come to Shasta with staggering student debt, entered the National Health Service Corps loan repayment program, and through their service, many are debt-free in just a matter of years. Thankfully, Congress has extended the core through this September, and we're very concerned that another expiration of funding would cause great damage to the program. Additionally, current funding only allows for awards of 40% of loan repayment applicants and a mere 10% of scholarships. H.R. 2328 and 1943 would fund even more applicants for loans and awards and thus substantially increase access. As CEO of the Community Health Center, a teaching health center, on behalf of all National Health Service Corps recipients, I urge Congress to provide increased and stable funding for these programs before they expire on September 30th. Thank you.
Thank you.